Fluoroless ablation is something that we could do already technically for a number of years. But we never really took advantage of all the additional tools that we have in the cath lab to cut down on the X-ray radiation for the patients as much as possible. So what this fluoroless ablation is all about is using the information from a three-dimensional mapping system as good as possible so that we can basically forget about X-raying to see where the catheters are. Which has two major advantages. Number one is obviously the patient gets less or no radiation. Now demonstrated we can do this even for atrial fibrillation ablations with absolutely zero radiation. So from the punctures, from A to Z, you can do this without exposing the patient to any X-ray. That's good for the patient because the patient has about a 70% chance in atrial fibrillation ablations to be cured in the first go. But a substantial number of patients have to come back for re-procedures, so they get exposed again. Some people need 3 or even 4 ablations. So every time they come back to an ablation procedure, they get exposed to X-ray again. So as much as we can reduce that burden, because the burden stays with the patient, it just continues through your lifetime. All the X-rays you've ever received accumulate in your body. And if you get either old enough or you had a lot of X-ray, your risk for cancer goes up. And this, of course, is a dramatic consequence. Now, the second advantage is for the operators, because we are performing these procedures typically manually, standing next to the patient or sitting next to the patient with lead shields on, lead aprons on, lead shields for the thyroid on, lead glasses if you're not too lazy. But it turns out that there is a substantial risk, professional risk for radiation as well for doctors and nurses. So there's data showing that the incidence of brain cancer is actually increased if you're an interventional electrophysiologist. And that is a substantial risk that not so many doctors are aware of nowadays. And that's where this awareness needs to start, number one. And then you need to learn how to use all the tricks that we have now to reduce our own exposure, and then in consequence also the patient's exposure. I think it's a matter of training, really, and people being aware of the fact that they are harming not only their patient, harming in parentheses, but also harming themselves. So if you do daily procedures in the cath lab, and every time you have, let's say, 10, 20 minutes of X-ray per procedure, and you do a number of procedures per day, the substantial burden that you have as a professional is actually significant. Now, we all have radiation badges. We are controlled by the national authorities that we are not exposed too much. But in fact, these are mostly passive badges. So we don't really know, we can't feel it, you can't smell it. It's just a number. Yeah? And very rarely, and I've never in my professional life, have I been warned that my radiation exposure has been too high. But as it's not felt, it's kind of an unknown kind of value. Yeah? But it has long-term consequences. So there are a number of colleagues that have passed away with cancer. Yeah, and that's the last thing that you want to have after a career in cardiology, is to just, after everything you've given, you should actually be fit and healthy still. Yeah? So radiation exposure is an important component for the professional in itself. And the second part is most of the doctors I know getting actually back pain from the lead aprons because they're heavy. Yeah, so there's a lot of data for orthopedic reasons that people would love to not wear lead. Yeah? And if you can do the procedure without any X-ray, then you don't need to wear your lead anymore. And I can tell you, even in atrial fibrillation ablations, I don't wear my lead apron anymore because I don't X-ray. I can do the procedure without doing this. I had a skiing accident once. I get back pain when I stand too long, and that it just makes my whole day easier, and I don't feel completely exhausted at the end of the day. So the way that we started doing this is we tried to use all the 3D mapping tools that we conventionally would use, not to the extreme, but to what they could actually do. They can show you the ablation catheter, they can show you all the diagnostic catheters as well. You need to learn a couple of tricks on how to advance, for example, your transeptal sheath in a safe manner in the right atrium before you go transeptal. And the last step was really to say, okay, we need to see the needle tip as well when we do the transeptal puncture in the most commonly performed procedure, which is the AF ablation. And there's a little trick. You can basically fake it and call the needle tip an electrode on most 3D mapping systems. And with that little trick, it's a hack if you want to. Yeah? You can see where that needle tip is, and then you don't need to X-ray to see where it is. Now, yeah, there are other ways of seeing it, but take every information that you have and really come to the point where you don't feel the need anymore because you know exactly where all the catheters are. 3D mapping is really the kind of the basic trick for doing it fluoroless. You need to know where the catheters are, and most of the catheters are now either sensor equipped or you can see them in an impedance field. So you could say, okay, I can have the picture of the heart of that patient ahead of time, for example, from an MRI scan, which is again fluoroless. And then you can basically just add with your catheter the electrical signals on top of it. That makes the procedure fast, and you don't need to X-ray.